To accommodate several previous requests on showing head and neck cases, we're showing this case today. It is obvious that the abnormality is seen on the right side, so let's concentrate on the normal left for the sake of normal anatomy. Let's highlight a few things here. This is the submandibular gland. This important landmark muscle is the sternocleidomastoid. Could be easily seen attaching the sternum to the mastoid bone. Let's show the sternocleidomastoid again, this here, and as you go all the way up, it attaches to this mastoid bone. Another landmark that is important is this gland here. This is the parotid gland. We showed the parotid gland on previous clips, and we talked about its superficial and deep components. Following a few important vessels, you could see the internal jugular vein and the common carotid artery. This is the aortic arch, giving rise to the common carotid artery, which goes all the way up, and then it bifurcates into its internal and external carotid components. So this is your carotid bifurcation. In this patient, there is some atherosclerotic change at the bifurcation, but these are your two vessels. This is the nose, this is the nasal cavity, and the space that's at the same level is called the nasopharynx. Scrolling downwards, you'll see another space that's opposite to the mouth. As you see, these are the teeth. In simple terms, this space here is called the oropharynx. So finish the nasopharynx, and this is the oropharynx. There is some distortion of the oropharynx that we'll discuss in details later. But let's go all the way downwards to look at this structure here. This structure is the epiglottis, which is normally seen on the left side but is distorted due to the abnormality on the right side. The space in front of the epiglottis is called vallicula, and the space behind it is called the piriform sinus. To clarify, the vallicula is an air-filled space anteriorly. This is one on the left, and this is distorted on the right. And the piriform sinus is a posterolateral structure, also filled with air, clearly seen here on the left. While it's also distorted on the right side, and we'll talk about that in more details later. A few important cartilages that we discussed before, from above below, the hyoid, the thyroid, and the cricoid cartilage. For juniors, if you're wondering, this structure that's draped in front of the trachea is the thyroid gland. This is your mandibular bone, and this here is also an important landmark. This is the angle of the mandible. Now that we highlighted a few important landmarks, let's look at the abnormal side. Corresponding to the patient's presentation of painful right neck swelling, there is this abnormality on the right side. To clarify, this is the abnormality here. Now, this finding has an internal component that's low in density and consistent with fluid. It has a bright, thin, enhancing rim and shows surrounding fat stranding, which we talked about in previous cases, denoting inflammatory changes. Compare the subcutaneous fat and the fat surrounding the lesion on the right side to that looks really clean on the left side. Not only that, notice the difference in the density and size of the right compared to the left sternocleidomastoid. The right sternocleidomastoid is enlarged and has a low density suggestive of edema. Do the same in comparing the right parotid gland with the left. The right parotid gland is enlarged and has increased density. The increased density of the right parotid gland is likely due to hyperemia, along with the enlargement are consistent with inflammation of the gland as well. Inflammation of the parotid gland, the sternocleidomastoid, and the surrounding fat tells us that this is an inflammatory process, and that the abnormality is not purely a simple cyst. A few important things to talk about is the location of the abnormality. It's close to the angle of the mandible. It also has an elongated appearance from above below as we scroll here, and it lies on top of the right sternocleidomastoid. This is a coronal image to better appreciate the elongated appearance of this cystic abnormality. And here's a sagittal image as well, showing this elongated cystic structure. Interesting finding is this very dense partial rim here in the inferior part of the abnormality, which could represent either calcification in the wall or milk of calcium, that calcium that deposits within the dependent portions of the cyst. Whether it's mural calcification or milk of calcium, this tells us that this is not a very acute abnormality. It has been there for a while for calcium to develop. It's very important to notice, as we described before, that there is distortion of the right side of the oropharynx, meaning that the lesion is not as isolated superficially as we think. It has a deeper component. Now there's fullness in the right side of the oropharynx, obliterating the right-sided vallicula and the piriform sinus. And there is fullness in this space, and this important space is called the retropharyngeal space, the space behind the pharynx. Now this low-density fullness tells us that the inflammation is extending into that area, but you don't have a well-defined enhancing rim to suggest abscess. This lateral aspect of the airway could simply be called the tonsillar fossa, so the tonsillar fossa is full. Now to a subtle but very important finding. Let's look at the normal bifurcation of the carotids here. If you look at the space between the internal and external carotid arteries, you'll notice that it has clean fat, apart from this normal small lymph node. Now let's compare that to the space on the right side. So the carotid bifurcation space here is full and stranded. And this appearance suggests that the inflammatory process is extending in between the space, connecting what we see internally to that externally. Putting everything together, an inflamed cystic structure that suggests a long-standing nature, with a likely sinus tract connecting the outer component with the inner component as it passes in between the internal and external carotids. An overall appearance that is consistent with something called a branchial cleft anomaly. A branchial cleft is actually a normal embryologic structure. Simply, this embryologic structure gives rise to multiple components within the neck as we develop. Embryologically, there are 5 branchial clefts, the first 4 of which could give anomalies. This branchial cleft could remain as a cyst, a sinus tract, or a fistula. And although this is a congenital anomaly, it manifests in late pediatric age or adulthood, either because it increased in size and it has a dysmorphic appearance, or it's painful, or gets infected or traumatized. So it's there for a while, and this explains why we see this calcific component here. And it's now clear why this patient presented now at the age of 60 years old. It's because it probably got superimposed by infection. As we mentioned, you have 4 types of branchial cleft anomalies. We will not discuss all of those today. But I will emphasize that the type that you're seeing here is the commonest. This is the second branchial cleft anomaly. About 95% of branchial cleft anomalies are of the second type, and the way I remember this is second is too common. So if you see a branchial cleft anomaly in real life or in exam setting, it will likely be the second type. The second branchial cleft anomaly lies on top of the sternocleidomastoid with a cystic component that's most commonly seen at the mandibular angle level. It could be a pure cyst, or it could have a sinus or fistulous component with the tract leading all the way to the tonsillar fossa, classically running in between the internal and external carotids. And that's why this space here is stranded. Now for a few things that you have to mention in your report. Talk about lymphadenopathy, and we saw here a few mildly enlarged and reactive lymph nodes. Then talk about the status of the vessels and airways, so make sure they're not compromised. For example, the carotid could have a mycotic aneurysm, or the internal jugular vein may have thrombosis. Make sure the airway, in this case in particular, is not really compromised, and although it's narrowed at several levels, it's not obliterated. And here's an important one. Always double check the retropharyngeal space and make sure you don't have a well-formed abscess. This is important for two big main reasons. A retropharyngeal abscess may compromise the airway. The other reason is that there is something called a dangerous space here, and this goes all the way to communicate with the anterior mediastinum. And that's why retropharyngeal inflammation or abscess could extend all the way into the anterior mediastinum, causing serious mediastinitis and mediastinal abscesses. So part of your report should talk about that. You should make sure that the anterior mediastinum is clear. The appearance is so classic that you see it once, you know the features, and you're not going to miss the diagnosis. However, there's a differential diagnosis that you could throw in. If the patient had trauma, surgery, you might have a localized abscess in the area. This could be a necrotic lymph node from infection, lymphoma, or metastasis. However, in that case, you'd expect to see more lymph nodes and more soft tissue component. A primary tumor such as sarcoma or schwannoma could be necrotic, but in that case, you'd expect to see some more soft tissue components as well. You may also think about a vascular abnormality such as a thrombosed aneurysm, but in that case, you'd have some more enhancement and connection to a vessel. Another vascular category would be of lymphangioma or venolymphatic malformation, and these could be superimposed by infection. Now, one entity that is not in the differential diagnosis and that many juniors would mention when seeing something like this is a thyroglossal duct cyst. Compared to the lateral location of this abnormality, a thyroglossal duct cyst is an abnormality that's midline or paramidline. You may see the appearance and the discussion around thyroglossal duct cysts on one of our prior clips, which are saved on the YouTube channel. As a radiologist, your role might extend to aspirating such a lesion under ultrasound guidance, and this is the ultrasound appearance. And this is the needle as it's traversing the soft tissue to reside within the abnormality, which was aspirated and yielded pus. This is the CT scan on the same patient after aspiration a few days later, showing you that the lesion has disappeared. And even the associated deeper inflammatory component due to the sinus tract has improved with less compression on the airway, with minor residual inflammatory changes seen in the right side of the neck. Now let's summarize what we learned from this case. We talked about a few normal anatomical structures such as the submandibular gland, the parotid gland, and the thyroid gland. We highlighted the mandibular angle, the sternocleidomastoid, and the bifurcation of the carotid artery. We talked a little bit about the nasopharynx and the oropharynx, showing the vallicula and the piriform sinus. We showed a classic appearance of a second branchial cleft anomaly, a cystic lesion with a sinus tract. The location of this lesion is typically at the mandibular angle, abutting the sternocleidomastoid. And if a sinus tract or fistula is present, is very characteristic, and it extends in between the bifurcation of the carotid to reach the tonsillar fossa. Differential diagnosis includes a necrotic lymph node, a necrotic tumor, or a vascular abnormality, but does not include a thyroglossal duct cyst. Abnormalities, make sure you don't have lymphadenopathy, airway abnormalities, or vascular compromise. Be more specific in describing retropharyngeal inflammation and abscess, and make sure that does not extend through the dangerous space into the mediastinum. As for the commonest of the branchial cleft cysts, it's the second type, too common. Radiology may have a role in aspirating these infected cysts under ultrasound guidance. That's it for today's case, which had lots of teaching points. Please share your comments, and see you later. This is a chest x-ray on a 29-year-old female patient. It's a quick case to emphasize a few facts about imaging of lung nodules and masses. The abnormalities are obvious in the form of these well-defined lesions seen scattered within the right lung, and similar lesions also seen, although smaller in size, in the left lung as well. When describing a rounded lung opacity, it is called a nodule or mass based on size. If the lesion is smaller than 3 centimeters, this is called a nodule, and if it's larger than 3 centimeters, it's called a mass. The other thing to discuss is that the differential diagnosis of nodules and masses is a long one. When multiple bilateral, variably sized lung nodules and masses are seen, the most likely diagnosis would be that of metastasis. With this appearance, other differential diagnoses are less likely. However, in a young patient, you may consider infection. Particularly TB and fungal infections might give you what looks like large nodules and masses that are scattered and bilateral. What if the patient has a solitary nodule, a single nodule? The differential diagnosis is still long as well. But there are 5 common causes for an isolated pulmonary nodule. These are granulomas, carcinomas, hamartomas, carcinoids, and isolated metastases. In this case, despite the young age of the patient, this was metastasis from a thigh sarcoma. Let's summarize what we talked about today. The first thing is that a 3 centimeter size decides whether you're going to call this a nodule or a mass. The commonest reason to have multiple bilateral variably sized nodules and masses would be metastasis. However, think about fungal infection and TB. The differential diagnosis for a single lung nodule is long, but there are 5 common causes. These are granuloma, carcinoma, hamartoma, carcinoid, and metastasis. Even in a patient who is young, metastasis is a high consideration since many malignancies may occur at young age. Thank you for watching. More cases later this week. The patient has bilateral pleural effusion, and he has lung changes that I want to emphasize on today. We have all those thickened lines which are not usually seen in a normal lung. This is thickening of the interstitium. Now, what is the interstitium? It is basically the connective tissue network that holds the lung. In many ways, this connective tissue background acts as the lung's skeleton. This line of the interstitium here is called a septum. So all of these are septae. Only a few scattered and incomplete thin septations may be seen in a normal lung. When you see multiple septations that are thicker than usual, this is called interlobular septal thickening. Now let's stop here for a minute to learn something that is extremely important. Note how those thickened septations form complete or incomplete geometric structures. Here are a few of these geometric structures outlined. So this geometric structure is called a secondary pulmonary lobule, or for simplicity, pulmonary lobule. A pulmonary lobule is the smallest building block of the lung, and you have to understand it before reading any high-resolution chest CTs. So what composes this secondary pulmonary lobule? The first is the edge, which is composed of these connective tissue septations. Septations separate the lung parenchyma, but in the center of this structure, you have 2 things running side to side. You have a small airway highlighted in blue and an adjacent pulmonary vessel highlighted in red. So the small airway and the small pulmonary artery run in the center of the pulmonary lobule, while pulmonary veins and lymphatics run in the periphery within the septations. Now to the next point. When you're talking about thickening of the septations, you have to divide it into smooth, nodular, or irregular. In a previous clip, we chatted a little bit about the differential diagnosis of irregular septal thickening. In this case, the thickening of the septations is smooth. So what is the differential diagnosis of thickened septations of the lung? To approach that differential diagnosis, you need to know if the presentation is acute or chronic, because it's different for each category. We know from the history that the patient presented with acute shortness of breath, so the differential diagnosis is that of acute smooth septal thickening. The first differential diagnosis is that of pulmonary edema from cardiogenic or non-cardiogenic causes. And if you think about it, this is not surprising, since with pulmonary edema you have congestion of the veins and lymphatics, and that's why these become thickened. The second cause of acute septal thickening would be infection, in particular atypical pneumonias, also known as interstitial pneumonias. Classic causes would be viral infections, chlamydia, and mycoplasma. The third differential diagnostic possibility is that of hemorrhage. In fact, it's not acute hemorrhage, it's subacute hemorrhage. Since hemorrhage or blood seeps initially into the alveolar space and then it gets resorbed after 3 to 4 days into the septations, and that's why it's seen in the subacute phase. But this may be seen in what's thought to be an acute presentation on imaging, since hemorrhage may be recurrent, so you could catch the patient at the stage of septal thickening with hemorrhage. Finally, the last differential diagnosis is eosinophilic pneumonia, and that's a very rare entity. You wouldn't raise it unless you know that the patient has eosinophilia. The story of this patient is that he had a viral-like illness for a few days that was followed by chest pain and shortness of breath acutely. This was accompanied by acute elevation in the cardiac enzymes that dropped a few days after. So putting everything together in this case, he had acute myocarditis, acute cardiac dysfunction, and acute pulmonary edema. Let's summarize what we learned from this case. We learned that there is something called the interstitium, which is the backbone of the lungs. We learned that part of the interstitium is called septations. Septations form geometric structures, which are the smallest building blocks of the lungs, called the pulmonary lobules. A pulmonary lobule contains veins and lymphatics in the periphery and a small airway and adjacent small artery in the center. We now know that these septations may be abnormally thickened, and if you see that, divided into smooth, nodular, or irregular. The differential diagnosis of smooth interlobular septal thickening depending on whether it's acute or chronic. The differential diagnosis of acute septal thickening includes cardiogenic and non-cardiogenic pulmonary edema, atypical pneumonia, subacute hemorrhage, and eosinophilic pneumonia. That's it for today's case. Thanks for watching. Send us your comments as usual. See you later with more cases.